First of all, I'd like to welcome Mitra, who is he's trained in Cambridge and London and undertook his PhD in neonatal neuroprotection at University College London. Suba is a welcome career development clinical fellow and honorary consultant at UCL. And I'm really looking forward to hearing about his work. His lecture is entitled Optical Neuromonitoring in Neonatal Encephalopathy. Suba, welcome.
Thank you, Professor Ear. And I'm delighted to present the work that we are doing in UCL and UCLH for the last few years. And some of you will see that the data that I'm going to present have already been presented over the years in previous meetings. So I'm going to touch very briefly about the clinical problem, neonatal encephalopathy and related neonatal seizures, and how an optical monitoring or near-infrared spectroscopy can fit in to benefit us, and what are the options that we have available commercially, and then focus on the limitation of the commercial instruments and how we can take it further to improve that. And as I've said, that I'm going to talk a little bit about what we have done over the last few years, and to talk a little bit about what we are going to do. So we all know that neonatal encephalopathy is a significant cause of neonatal mortality and morbidity. We started hypothermia almost 10 years ago, but we still know that more than 40% of these cohorts still have significant death or disability. Now, we have also some new data coming on to say that the babies with mild neonatal encephalopathy still have significant problem with their cognitions when compared to the controls. And we now know that more and more trials showing us that hypothermia is not neuroprotective in low resource setting. So if we look at the global data of neonatal encephalopathy and neonatal mortality, this was Joylon's data from 2014, which actually shows intrapartum cause of around 23% of total neonatal mortality. Going forward, this was WHO data from 2017, and still intrapartum events 24%. So that percentage almost staying the same in spite of introduction of hypothermia in the developed countries. And with neonatal encephalopathy comes neonatal seizures. And if we look at the proportion of the neonatal seizures that are caused by neonatal encephalopathy, you can see that almost half of the neonatal seizures are caused by encephalopathy. We know that neonatal seizures are very tricky. The diagnosis is challenging. The evidence base for managing clinical seizures is difficult, although it's the most common neurological emergency within the newborn period. And this period has the highest lifetime risk for developing seizures. And if you look at different studies, almost up to 80% of the neonatal seizures are subclinical, which actually makes it even more difficult. The seizure burden is always greatly underestimated. This is just the data from one study, and where you can see the black area indicates the electrographic seizures, and the gray area indicates the clinical seizures, and how different is that. So what do we have as a currently usable continuous neuromonitoring tool in the NICU? Well, we have neurophysiology monitoring, or the EEG. Now, the problem with that, very few units have a support system to run a 24-hour EEG. We can do that in UCLH, but we know that it needs a significant support from the neurophysiologists. There is also the option of amplitude-integrated EEG. But the problem with amplitude-integrated EEG, that the detection of seizures is very much unreliable on that. And also there is increased artifacts on amplitude-integrated EEG. So it's clear that we need a tool for real-time continuous monitoring within the neonatal intensive care unit, which can give us an early assessment and stratification of injury, can monitor the pathophysiological change as the injury progresses and evolves, and maybe develop some courtside biomarker that can tell us about the future outcome much early on. So near-infrared spectroscopy is an optical tool that can fulfill those criteria, or at least have the promise. So we know that the biological tissue is transparent to near-infrared light. We can shine a light in the near-infrared range on the baby's head and detect the light that's coming back. Now, using the physics algorithm, we can change the intensity of the light that's coming back to the concentration change of certain chromophores that absorbs light, like hemoglobin and cytochrome C oxidase. So near-infrared started mostly with oxy and deoxyhemoglobin, and we can measure the concentration changes of oxy and deoxyhemoglobin, and from that we can derive certain other markers, like total hemoglobin, which indicate the changes in the cerebral blood volume. We can also have hemoglobin difference, which indicates cerebral oxygenation. But we doctors need some absolute numbers, like peripheral oxygen saturations. So the commercial companies then picked it up and produced something called cerebral oxygen saturations. And if you look at different companies, have got different names. Some call it STO2, some call it RSO2, some call it TOI. But that basically is the same, which is the cerebral oxygen saturation. And it is the percentage of oxyhemoglobin out of your total hemoglobin, pretty much the same way that we calculate our peripheral oxygen saturation. But the difference is the peripheral oxygen saturation is measured in the arterial field. But here, the cerebral oxygen saturation is mostly measured in the venous component because we want to know what the tissue perfusion is looking like. And it indicates a balance between the oxygen delivery and utilization. Now, let's take a step back and try to think about how we can use these NIRS in monitoring of the neuronal activity. We know that with any neuronal activity, there will be some metabolic activity and there will be some vascular activity. Now we have these parameters. So we have got total hemoglobin, hemoglobin difference, and the peripheral tissue saturations from the commercial oximeters. So we can get an idea about the hemodynamic changes associated with any neuronal activity. And we can also derive a marker which is FTOE, or fractional tissue oxygenation extraction, to get some idea about what's happening within the metabolism. But we need to remember that that marker is actually derived from the hemodynamic marker. It's not a true metabolic marker. But we have got another option. I measured early on that cytochrome C oxidase is another compound that absorbs light, and we can measure that using broadband near-infrared spectroscopy. So here is a kind of a caricature of the electron transport chain. Now, electrons flow through the electron transport chain, and here is the cytochrome C oxidase, or the complex 4. Now, when the electrons flow through that, and cytochrome C oxidase is the terminal electron acceptor, which then creates an electrochemical gradient between the two sides of the inner mitochondrial membrane, which then kind of stimulates ATP synthase, which is basically a circulating enzymes, and then stimulates ATP production. So if we can measure changes here, we can get an idea about what's happening with the bioenergetics within the neuron. So that's the idea. So cytochrome C oxidase has got a central role in mitochondrial oxidative metabolism and ATP synthesis, and it is not new. So first ever paper published in Science by Jopsis on near-infrared spectroscopy in 1977, if you look at it, he tried to measure cytochrome as well as hemoglobin parameters during asphyxia and normoxia on a cat's head. But the problem is, it is difficult to measure. The reason is the concentration of cytochrome C oxidase is very, very low. It's almost 1/10 of the hemoglobin concentration. So we need an appropriate multi-wavelength system that can measure cytochrome C oxidase accurately. And we are lucky in UCLH because we had a very good collaborations with the engineers and medical physics in UCL, who made us this wonderful system for us, which is a purpose-built broadband near-infrared spectroscopy system which runs on 136 wavelengths. And just to give you an idea, the commercially available oximeters use 2, maximum 4 wavelengths for measuring hemoglobin. So now take a step back again and see what we have got our tools. So we have proton spectroscopy, is part of our clinical tool nowadays, phosphorus spectroscopy, which is still not a clinical tool, and we now have broadband near-infrared spectroscopy. And if we want to interrogate the cerebral oxidative metabolism, if we look at this flow chart, glucose through glycolysis produces pyruvate. If there is enough oxygen, it produces acetyl-CoA, which then goes within the mitochondria, within the TCA cycle, and produce NADH. And this NADH then goes through the electron transport chain and stimulates production of ATP. Now, with proton spectroscopy, we can measure cerebral lactate. With phosphorus spectroscopy, we can measure what's happening with the ATP. And with broadband near-infrared spectroscopy, we can measure changes in the cytochrome C oxidase, which is then a proxy marker of your ATP production. So now we have got few tools that can give us an idea of changes in the cerebral metabolism. We have seen this graph many times in many talks. So this is basically based on phosphorus biomarkers, which tells us how the brain energy states changes during the hypoxic ischemic insult, resulting in primary energy failure and following that secondary energy failure. And this was over time. Now we wanted to see that how our cytochrome C oxidase perform along with the phosphorus biomarker when we produce an hypoxic ischemic insult. So here, just one preclinical model and one piglet. Here over time, this is on your y-axis, again NTP EPP, which is basically brain energy state. We induce hypoxic ischemic insult, it drops, and we start resuscitation, and it starts to recover. And the green line shows the changes in the cytochrome C oxidase, and you can see that how that goes hand in hand. And what we saw that actually cytochrome C oxidase starts to drop even before the phosphorus biomarker starts to drop. And even with the recovery, it responds to resuscitation much quicker as well. And we did that, we looked at in a group of piglets. Here you can see each color represents a single animal. And here the A is the insult and B is the start of the resuscitation. So you can see the changes in the NTP-EPP. In the middle, you can see the changes in the cytochrome C oxidase. And when we put them to find the correlation, you can see that they are strongly correlated. So this gave us a confidence to bring this tool to our neonatal intensive care unit to run the clinical study. So here you can see that we run a 24-hour EEG on babies who are being cooled. And believe me, there's a baby behind this desk. You can see there's a 33.5 degree centigrade cooling. The other parameters here, the ventilators, and here is our system. So this is our broadband near-infrared spectroscopy system, and this is actually a clinically or commercially available clinical oximeter. So we started both together. And this was the baby who was hidden behind, and you can see that the probes are on the forehead, and the cables are coming here and going to our system. Now, what do we already know what happens in neonatal encephalopathy? So we know that there is a change in the vascular tone. There is a vasoparesis, which then leads to impaired autoregulations and leads to further neuronal injury. We also know that the infants with adverse outcome following neonatal encephalopathy had a longer duration and a higher magnitude of the cerebral pressure passivity. Now, all these studies only looked at the hemodynamic component rather than the metabolic component. And the other limitation was that there was an assumption of a stationary relationship between the cerebral and systemic variable. So cerebral autoregulations is not a static thing. So it's basically changes with time as well as with frequency. So it's a dynamic nature, and the previous studies did not actually look at that dynamic nature. So we looked at 23 infants who were undergoing hypothermia, and we used wavelet analysis. Now, wavelet analysis is a signal processing technique that gives us an idea what's happening over time and also in particular frequency range that we are interested in. And I will show you an example in a minute. We calculated coherence between the two variables, and the variables that we use mean arterial blood pressures, and broadband near-infrared spectroscopy variable. Cytochrome C oxidase gives us metabolic reactivity, and hemoglobin D gives us hemodynamic reactivity. So the coherence indicated the strength of the relationship between two variables. So it goes up from 0 to +1. We also calculated something called semblance, which gives us an idea about the change of the phase difference between the two variables. So it goes from -1 to +1. So when the semblance is 0 to +1, or means it's positives, then it shows the signals are varying in close alignment. So that tells us that the brain is passive reactive, which is not a good sign. If it's 0 to -1, the signals are in antiphase, which gives us an idea that the brain is preserving the reactivity. And we then created a mean reactivity indices over 1 hour of study period. So here's an example. On the left, a baby with a good outcome. On the right, a baby with a poor outcome. And I'm just showing a particular metabolic reactivity analysis here. So on our x-axis is the time. On our y-axis on the top, this is the blood pressure recording over that time frame. And then in green, we have the cytochrome C oxidase. And then we calculated the semblance. And the way that I use the color map is from 0 to +1 becomes more red. And if it's become more negative, it becomes more blue. So without looking any numbers, if you look at this graph and see that this is more blue, that means the reactivity is preserved. And if it's more red, that's a danger sign. So reactivity is more positive here. And we are looking here on the y-axis is the frequency range. So we know that the slow wave range is the most appropriate range to look for cerebral autoregulatory changes. And we can see that here. So the beauty of this analysis is that you can see over time and over frequency how the two variables are changing. All these babies had MR scan and proton MRS between day 5 and day 7. And we used thalamic lactate Na as our outcome biomarker. We used NICHD MRI brain scoring system, and we used Bailey 3 scores for our neurodevelopmental outcome. So here we looked at first that how the cytochrome blood pressure semblance or the metabolic reactivity relates to our thalamic lactate Na. And we saw there was a relationship there. So what it's telling us that higher the thalamic lactate number is higher is your cytochrome blood pressure semblance. So in severe babies who have higher lactate Na, they have passive brain reactivity from the metabolic point of view. And then we grouped babies on the basis of lactate Na, and we looked at whether our metabolic reactivity actually can differentiate those two groups, and they were statistically significant. We looked at the MRI scores, and we created two groups on the basis of 2B on NICHD scoring system. The reason behind that was that if we look at MRI score greater than or equal to 2B, it was highly predictive of death or IQ less than 70 at 6 to 7 years of age. And you can see that cytochrome blood pressure semblance again was highly significantly different between the two groups. We looked at our death or motor disability and normal outcome. Again, our metabolic reactivity was really significantly different between those two groups. We published in details with the hemodynamic reactivity as well, which was significant, but not as significant as the metabolic reactivity. I'm not going into those details. And we looked at the coherence as well between those signals were not as significant as the semblance. While we were doing this analysis, we noted something interesting, that lots of these babies who were on ventilator had periods of desaturations noted when we were monitoring. And we looked at the babies based on thalamic lactate in a good outcome and poor outcome. And we looked at how this baby responds to those desaturation episodes. So here's an example of a good outcome babies, and you can see here's the time frame, and this is our peripheral oxygen saturations. And you can see that there is a drop from 95% to almost 75%. And here how the baby reacted. So the green line is your cytochrome C oxidase, and your blue line indicates the changes in the cerebral blood volume, and your red line indicates your drop in the cerebral oxygenation. In comparison to that, if you look at a baby who had a poor outcome, you can see that period of desaturation was much less than this. And also it was less deeper desaturation because it's there around 80%. Here we had up to 75%. But in this baby, within that desaturation period, the cytochrome dropped dramatically. And the cerebral blood volume remains pretty much the same. And there was a drop in the oxygenation as well. And you can see their respective MRI images, how different they are. So we could see that this is probably indicating that the mitochondrial injury that was much more severe in the poor outcome group. So we can say that the pressure passive changes in the cerebral metabolism at 48 hours of life while being cooled were associated with injury severity that we measured on thalamic lactate NA, MRI scores, and neurodevelopmental assessment. Now, the problem we had that most of our babies come from level 2 and level 1 units. And by the time the baby comes in, the mother still stays in the local unit. And we struggled to get consent and start the study before 48 hours. We now have telephone consent and we have started study much earlier. So we felt that these indices needs to be validated early after injury because we need an early biomarker. Because at 48 hours, probably the injury is all set. Now, we can also say that cerebral metabolic response to hypoxia depends on injury severity following neonatal encephalopathy. Now, while we were doing these studies, we realized that we were still using a thalamic lactate cutoff, thalamic lactate NA cutoff, which was prepared before the cooling period. So on the pre-cooling era, thalamic lactate NA was the most robust MR outcome, but this was done on 1.5 Tesla. And we know that following the introduction of therapeutic hypothermia, lots of biomarker actually lost specificity and sensitivity to predict outcome. So we wanted to look at how we were doing with the thalamic lactate NA in the new hypothermic era. This is the area where we put our area of interest, and here is an example of moderate encephalopathy baby. You see this NA peak and then small lactate peak, but the lactate peak grows bigger when we have a severe encephalopathy baby and the NA drops. And we saw that lactate NA in the hypothermic era, using a cutoff of 0.39, we were able to actually predict the death or poor neurodevelopmental outcome at 2 years of age with a sensitivity of 100% and a specificity of 97% for motor outcome, and also quite significantly for cognitive and language outcome. And in subsequent study, we used that new cutoff. And we looked at, on the basis of that cutoff, the groups of babies of good and poor outcome on all the 3 different domains of development. And you can see that in all the cases, they were statistically different. Now, while we were monitoring the babies with neonatal encephalopathy, we also monitored them for seizures. Now, here's the data I think I presented early in the Neonatal Society a few years ago. So this was a baby came to us following placental abruption with moderate encephalopathy. We completed the hypothermia and we were rewarming this baby. And we saw that at 80 hours of age, this baby started to have seizures. And the seizures were repeated, so we had to restart hypothermia. This baby was subsequently treated with phenobarbital. So this is quite a lot of data here. So on the top, we have got the EEG, amplitude integrated EEG and the broadband near infrared spectroscopy data. And in the lower part, we have the systemic variables. S1, S2, S3, S4, S5 indicate 5 seizure episodes. So if we first look at these purple lines, which indicate the amplitude integrated EEG, you can see the seizures. And you can see the changes in the cytochrome C oxidase. In the green, you can see the changes in the black, which is the cerebral blood volume, and the red is cerebral oxygenation. And if we look one of those, I'll come back to that. So this is the EEG that was running at the top point. On the amplitude integrated EEG panel, you can see those 5 seizures. And on the 4th panel, you can see that how the raw EEG was looking like. So if we focus just one of those seizures, so here the gray area indicate the seizure duration that was calculated from the raw EEG, and on your x-axis will be your time, and your y-axis on the top is the cytochrome C oxidase changes. So you can see that as soon as we started seizures, there's a rise in the cytochrome C oxidase, which then started to fall even before the seizure stopped, and it actually falls below the baseline. And brain oxygenations initially dropped, blood volume dropped, which both then recovered. Now, looking at these data, we can say that there was a rapid increase in the cytochrome C oxidase at the onset, which indicated an increase in the mitochondrial oxidative metabolism that you'd expect when all the neurons were firing together. And there was a progressive fall in the cytochrome C oxidase during repeated seizures, which indicated a depleted mitochondrial energy state, which probably can explain why the repeated seizures or a prolonged seizures develop a hypometabolic state and produce further injury. Now, as we continued to monitor, we monitored many more babies with seizures. And here comes another example. This is important. This was another town baby, was really severe HIE, and this baby was being cooled. Now you can see easily from the amplitude integrated EEG that this was a quite flat electrical activity. And if you look at the raw EEG and look at them very carefully, you can see there's a low amplitude seizures going on in certain areas. We monitored this baby and we captured 10 seizures again. So these gray bar are the area represented as seizures. And you can see the time frame here over 1.5 hours. Again, in the lower half, these are the systemic variables. In the upper half, here in the blue is the amplitude integrated EEG. And on the green is the cytochrome changes. Black, again, the cerebral blood volume. And red is the cerebral oxygenations. But if you look at amplitude integrated EEG, there wasn't much change. But if you look at the broadband near-infrared spectroscopy, we could see there was repeated changes and significant changes going on. So let's focus a little bit more on two of those seizures. So we know that amplitude integrated EEG are not great for picking up low amplitude seizures. And you can see that here. So again, this gray area is the seizure period, and you can see there hardly any change in the amplitude integrated EEG. But you can see that the brain metabolism, again, immediately increased. The brain oxygenations increased and the brain blood volume increased. And we also calculated cerebral oxygenation as it is calculated by the cerebral oximeters. This is commercially available cerebral oximeters. And you could see that there is hardly any change during the seizures. Now, let's put two together. So this was the first baby. This is the second baby. So this baby had a good outcome even after multiple seizures. This baby had a much poorer outcome. We look at the brain metabolism, there is increase in the cytochrome C oxidase in both cases. But then have a look at the brain oxygenation and blood volume. This is completely different picture in these two babies. Okay. We can't answer that with our current setup. What we have in the previous studies, this is Geraldine Boylan and Janet Rennie in King's, where they actually looked at Doppler studies in seizures, and they kind of noted that there was an increase in the cerebral blood flow velocities in 10 babies that they looked at. But we did see there was completely different hemodynamic response in two babies. And it has to be because there was a cerebral blood flow response are different in two babies along with different reactivity. But we can't still answer that with our setup. So what happens after the seizures? So if you follow the EEG, when there is a seizure, we give phenobarbital, and most of them actually respond, and there is a drop in the amplitude in the electrical activity, and then gradually the electrical activity comes back to normal. But if you look closely, even if there is a lack of electrical activity in the post-seizure period, the brain actually does have significant changes in the other aspects. So this was a study was done with an UCL diffuse optical tomography system, which is used for imaging. And we looked at babies after the seizures, not during the seizures. And you can clearly see here's a baby with a left middle cerebral artery stroke. And what we noted on the left side, there were spontaneous transient hemodynamic changes happening almost 90 seconds of each event. But on the right side, we didn't see anything. At that point, we didn't have any systemic variables to compare whether these were coming from any systemic stimuli. We didn't have any metabolic component as well. So we didn't manage to comment where they were coming from. Here is another baby that we now actually looked at using broadband near-infrared spectroscopy. So this was a baby that came from, a local unit. And I remember the father on arrival showed me a video on the phone, which actually clearly was showing at 9 hours of age, this baby was having right upper and lower limb jerking. By the time the baby came to us at around 17 hours of age, the baby had multiple drugs, and there was no further seizures when we put the EEG on, but it was quite suppressed at this point. We studied this baby for 3 hours. And this was the left side of the brain. And you could see these spiky changes that was going on within the brain on the left side. This was the right side of the change. And remember, this is the period where the EEG is not showing any significant electrical activity. There was no change and was quite suppressed as well. And this was the systemic data didn't show any significant changes. And when we looked in further details of individual events, this looked pretty much similar to what we published before. So these were, again, each color indicates one single event. And these were the left-sided changes, these were the right-sided changes. Now you see these changes happening in oxyhemoglobin, hemoglobin total, blood volume, cerebral oxygenation, and cytochrome C oxidase or cerebral metabolism. But it was different in two sides. And when we tried to look at how the brain was responding, how the cerebral oxidative metabolism was responding in compared to available oxygenations, we could see there is a complete difference between the two hemispheres. So we could understand that there was some problem with the hemispheric asymmetry. And on day 5, when we took the baby to the scanner, you can see this baby also had a middle cerebral artery infarct. Now, we could see these things are happening in the brain, both from the hemodynamic and metabolic side, but we couldn't answer what it was and why it was happening, because we didn't have any tools to identify what was happening in terms of cerebral blood flow continuously. Now, this is our setup again, and we couldn't answer what's happening with the cerebral blood flow. And we looked back and searched hard that can we actually measure cerebral blood flow from the data that we have? And we realized, yes, we can, because some of these babies had spontaneous desaturation events, and that can be used as a stimuli, because at the same time, we had brain oxygenations, and we also had our peripheral oxygen saturations. I'm not going into details, but using fixed principle, we can look at the cerebral blood flow. And we looked at 21 infants who had spontaneous desaturation events during this monitoring. We identified 67 infants, 22 from babies with poor outcome, and 45 from babies with good outcome. And this is what it looked like. In good outcome babies, you can see from day 1 to day 5, there wasn't significant changes in the CBF. But if you look at the poor outcome, what we know that significant hypoxic ischemic insult actually reduces your cerebral blood flow initially following a luxury perfusion. And that we can see in our data. We were lucky enough to have 4 babies where we had this desaturation event just prior to going to MRI on the morning. And part of our MRI research program, we do what we call arterial spin leveling program, which can monitor cerebral blood flow. So we wanted to look at whether the spontaneous desaturation induced cerebral blood flow measured by broadband near-infrared spectroscopy, whether there was any relationship with the frontal CBF that's measured by ASL. And we could see here, this is only 4 babies, but we could see here there is a clear relationship there. As we were looking at these options, we realized that there is another optical tool that we can use together to get an idea of continuous microvascular blood flow. and that's called diffuse correlation spectroscopy. So that gives us an idea about the continuous cerebral blood flow, and now because we have peripheral oxygen saturations, we can use that to continuously monitor cerebral metabolic rate of oxygen as well. So we're running 2 studies now. On the neolite study, we are trying to develop an early biomarker for stratification of injury following neonatal encephalopathy. And Kelly is going to present a very early data from our preclinical study, so I'm going to escape that. And we are going to run INSPIRE study, which is the investigating neonatal seizures with optics, neuroimaging, and EEG. So with the optics now, we have the options to look at mitochondrial metabolism, cerebral blood flow, oxygen delivery, and oxygen utilization, along with the video EEG, the structural and perfusion MRs, and then we have both proton and phosphorus MR spectroscopy, and we believe this will give us a deeper understanding of what's the impact of seizures have in real time in this group of babies. We have several work packages. We are going to first define metabolic and hemodynamic changes in healthy brain in a piglet model, because we can clearly see that depending on the injury severity, our cerebral blood flow changes. So we first need to understand what happens in a healthy brain and then correlate that findings with what happens in an injured brain. We're going to look at the immediate and long-term impacts of seizures in a clinical study, and we are also going to use our tool to look at what phenobarbital does to your brain in real terms and why some of the babies actually respond to phenobarb and some don't. So here's a flow diagram of how we are going to do our preclinical study. We have 3 groups of piglets, all male piglets, and then we have a control group, and then the middle group where we are going to induce some seizures using bicoculin, and in the third group we are going to use bicoculin, and we are going to treat them with phenobarbital. And we are going to use exactly the same neuromonitoring setup that we are going to use clinically, and the same MR sequences that we use our clinical babies as well. So our clinical study for INSPIRE is continuing, and we're going to start our preclinical study in 2 weeks' time. I'm going to stop there, and I'd like to thank a lot of people, my mentors and my collaborators and my funders as well. And I'm happy to discuss anything related to optical monitoring. Thank you.
Super, thank you. That was fantastic. Very clear, thorough explanation of some really quite complex and very important data. Congratulations.
Thank you.
So this Super is now, I'm willing to take questions. Does anybody have any questions that they would like to ask? Super, if I could just perhaps start things off. Where do you see this in 5-10 years' time? Where do you see these investigations? How are they going to identify babies where intervention to improve outcome is possible?
I think there are 2 aspects to it, actually. If you look at the neonatal encephalopathy, we don't have a really good tool on the basis of which we can look at or stratify the injury much earlier. We know that there are new neuroprotective agents are coming on the horizon. There are multiple trials going on. But who is going to benefit from these new neuroprotective agents? Are we going to give it to all of them, or we are going to stratify the injury and then give them as they need? So I think this can be answered using optical tools, and that's one part of it. And the other part is the seizures. So we know that this is an area where our understanding is really poor. So if you think about over the last 15-20 years, we don't have any new medications for treating neonatal seizures. And the reason behind that is we don't understand very well what seizure does in real time to babies. Does all the seizures need to be treated, or the seizures we can treat specifically to improve outcome? So I think those are the areas that we can improve over the next 5-10 years with these tools.
Great, thank you. Dr. Leaf.
Thanks, that was absolutely fascinating. And it's just amazing to see how this whole understanding of brain metabolism has evolved. But I just wondered, have you got data or have you studied longer term
No.
Are there long-term disturbances?
No, that's
Thank you. So I could just repeat that question for those people who are joining us online. So, as Dr. Leaf asked if there was any data, or longer-term data, in these patients over a longer period of time.
So we haven't have the longer term data yet, but that is one of the plans for us to do it. But at the same time, what we have started to do is just before the babies go home, we are doing the functional studies. That gives us some idea about what happens when all those muscle relaxants or sedations goes out of the body. And just before going home, which is probably 7 to 10 days after the initial injury, how the brain looks like. So once we have that data, we're going to compare that from the initial part. And then at the same time, we're also going to submit some applications to look at the long-term data.
James.
Thank you very much. Will you comment on the design choice to include male-only piglets in the preclinical study, and what your confidence will be that the findings can be applied to females?
So if I could just repeat that. Professor Boardman asked why only male piglets were selected for the study and what confidence you'd have that this could be applicable to female piglets.
I think that's a very important question. And we know that the pathway of injury is different between the males and females. We are going to do it only in the male piglets just because we needed to do it in a very short span of time, and the funding was not enough to kind of complete both male and female. That will increase the time frame, as well as we need more funds. But that will be something that we will look forward in future.
Any other questions? Okay, we don't have any questions from those people online. So Subha, thank you very much and congratulations once again.
Thank you.
Thank you.